Hi, my name is Sarah Mayer, and I'm going to be talking about malnutrition and aging today. So I really believe this is a topic that deserves increased attention due to the potential to increase health status in patients and really leave a positive economic benefit towards the healthcare system, towards institutions, and just the patient itself. So I'm going to start with So today I'm going to talk about why malnutrition in the elderly is a rising issue, what are the leading causes of malnutrition in older adults, how is malnutrition being assessed and how often, and interventions used to return the patient back to health. So why is malnutrition in the elderly a rising issue? And it's mainly because the life expectancy in the U.S. is continuing to increase. So since 1985 to 2010, the life expectancy of women has increased from 78 to 80.9 years and 71 to 76.3 in men. So in 2014, 14.5% of the U.S. population was 65 years or older, and in 2020 or in 2060, it's projected to increase or to reach 23.5%. So it's definitely people are living longer and they have greater needs and it really has an impact, economically speaking, on healthcare systems. So there's an increased use of resources, increased use in waste of healthcare money, and poor patient outcome results. And for the patient too, there is outcomes of malnourished patients are worse than well-nourished patients, and expensive healthcare bills are a problem in longer hospital stays for the patient. So it's a rising issue. Like I said, 3.7 older Americans are malnourished, so that's overall 32% of all older Americans in the United States are malnourished. The leading place you can find malnourished adults is in rehab facilities, which is 91%. Next is hospitals at 86%, nursing homes at 67%, and in the community at 38%. And malnutrition in aging adults is very common, but the exact prevalence is unknown due to the lack of diagnostic criteria and assessment and so as common as malnutrition is in older adults, it's underrecognized, underestimated, and it is untreated, and even in those settings where screening is required, it is undiagnosed. It most of the time goes undiagnosed. So malnutrition can occur due to undernutrition or overnutrition, and overnutrition would be overweight or obesity, which is you're consuming enough energy but not an adequate amount of nutrients. And it could also occur due to undernutrition, which is really what we're going to be focusing on today because it's more likely what would happen to an elderly adult and why they would become malnourished. So some reasons some of these adults would become malnourished and end up with an insufficient supply of nutrients would be because of malingestion of adequate food. So this could be from lack of appetite, which is called anorexia of aging, which is the natural decrease in senses and in smell and taste, and the increase in GI satiety, and so it decreases the urge for older people to eat. It could also be from physical or cognitive impairment, depression, or chewing and swallowing problems, preventing the patient from consuming enough or adequate foods. So another reason is maldigestion of foods, and so this could occur due to changes in the GI tract over time, and or GI diseases such as ulcer disease or pancreatic disease, and it could just lead to maldigestion of the food. Another reason is malabsorption or increased requirements of nutrients. So this could be due to drug-nutrient interactions, if the patient's taking a certain medication for an illness or for anything that it could affect the absorption in the stomach. Acute or chronic illnesses could increase the need, which could lead to, or which is also called disease-related malnutrition. And so this can occur in older adults, and it will increase their need. So what they would normally be consuming would not necessarily be adequate for their condition. The last reason is poor diet selection, and this could either be due to a lack of knowledge of what to eat, or or it could just be a low-income family and it's someone having trouble figuring out how they're going to actually attain healthful foods to eat. So, how is malnutrition being assessed? In past years, albumin, transferrin, all these acute protein labs have used to be used, and it was found that these were better indicators of inflammation rather than nutritional status. So since then they've developed screening tools to help diagnose malnutrition. So some of these screening tools include mini nutritional assessment, the malnutrition screening tool, and malnutrition universal screening tool. And so these tools should be quick, easy to use, valid, and reliable. They are established by registered dietitians, but they can be used with anyone who is trained to do so. So here's the mini nutritional assessment, what it would look like. This is the one that's most commonly used in healthcare systems today. And so I'm going to tell you a little bit about how it has gotten to where it is and the previous versions. So version number 1 came out in 1990, and this consisted of 18 questions. So this is very time consuming, which led to the production of version number 2 in 2001. So this was referred to as the 2-step process, and so it consisted of a first step of 6 questions, the short form, and then the next 18 questions were then used if the patient was found to be malnourished or at risk for malnutrition. So it would further classify where the problem is, or what or how to fix the problem. And so this leads to version number 3. So this is called the mini nutritional assessment short form. So it's significantly shorter than version number 1. It's only 6 questions, which makes it very quick and easy to use. And it's kind of small, so I'll read out some of the questions. So it asks food intake over the past 3 months. So if there's an increase and decrease in appetite or difficulty chewing or swallowing, anything to affect the food intake. Weight loss over the past 3 months. Mobility, so making sure they can still get out of bed, leave the house, and feed themselves just like they used to. Physiological stress or acute disease. Neuropsychological problems, and it also asks for BMI or calf circumference. And so these tests can determine if a patient is malnourished, at risk for malnutrition, or has a normal nutritional status. And generally, the lower the score, it indicates malnutrition or a risk for malnutrition. So why use the mini nutrition assessment? Studies confirm that the 6 questions in the latest version correlates highly with the version number 1, or the full 18 question mini nutrition assessment. So it has a very strong validity. It measures what it's supposed to measure, and it helps reduce the waste of resources, and it really helps identify those who needs to be helped, and it helps find patients that are malnourished to more quickly begin treatment, so that the sooner the treatment, the greater recovery rate. So also it takes less than 5 minutes. It requires no special training, no lab data needed, and it is free. So who uses the mini nutrition assessment and how often? Currently, mandatory nutrition screenings only occur in long-term care in hospital settings, which is crazy because there's elderly people in so many more settings, and so it could be so much easily used in so many more places, and it can diagnose malnutrition in places such as mandatory or for assisted living facilities, adult daycare programs, federal senior nutrition programs, home and community-based care, home health, medical homes, and physician offices. I really think registered dietitians and nurses or other health professionals really have this advantage to know about this assessment, this screening process, and help bring it into these settings and really help bring awareness to malnutrition in the aging adults. So geriatric nutrition screening, it should take place yearly and more frequently if individual is in home care, nursing home, or in a hospital to identify the risk before the problems occur. So if the screening tool identifies malnutrition or a risk for malnutrition, the next step would be to identify the type of malnourishment. So this is the consensus statement of the Academy of Nutrition and Dietetics and the American Society for Parental and Enteral Nutrition, and its characteristics recommended for identification and documentation of adult malnutrition. So it asks the nutrition risk is identified, and then it asks if inflammation is present. If no inflammation is present, this is most likely due to starvation-related malnutrition. So this can occur due to anorexia of aging or pure chronic starvation. If mild to moderate degree inflammation is present, this is most likely due to chronic disease-related malnutrition, so this could be from organ failure, pancreatic cancer, arthritis, or sarcopenic obesity. And if there's a marked inflammatory response, this is most likely due to acute disease or injury-related malnutrition. So this can be from a major infection, burn, trauma, and closed head injury, which would require an increased need in nutrients for the patient. So some interventions for malnutrition. Being malnourished can potentially lead to decrease in ADLs and can also lead to an increase in depression. So in a study conducted by Peterson and colleagues, it compared follow-up interventions for patients that were malnourished in a hospital setting. And so it compared it compared in-person nutrition counseling with phone consultation. And so the results, there was 192 malnourished patients, and they were all recently released from the hospital, and they all live independently at home. So there was 2 intervention groups, like I said. It was the phone consultation group and the home visit group, and then there was a control group. So in the beginning of the study, activities of daily living were all recorded in participants. So it was recorded once in the hospital before the discharge, another time right before the first counseling session, and then a third time after 8 weeks at the end of the study. So it was measured with a modified Barthel 100 index, which measures the patient's ability to go to the bathroom, eat, get dressed, and bowel and bladder control. And so, and other tests were also used, such as grip strength, health-related quality of life, depression list, and the geriatric depression score to determine if there was any difference in the increased rate of depression. So the results, all groups improved their activities of daily living, with the highest being the home visit group with 96%. The telephone group is next at 75%, and then the control group was 72%. So even though there was no differences found in the decrease in depression, it's definitely was found that the home visits have the most, the follow-up sessions, the home visit sessions have they're most effective in preventing deterioration of ADL function in geriatric patients. So the video wouldn't load, but I'll have it for class. This is an interview with a local dietitian who spends a lot of her time in nursing homes. And similarly to Ms. Denise's findings, she highly recommends in-person home visits to, which relates to the study I was just talking about. So she agrees that in-person consultations are most likely the most effective in finding the nutritional or what's going wrong and what's leading to malnutrition. So these are a few papers Ms. Denise kindly dug out of her office for me. So this is a referral form for a consultant dietitian, and it includes some topics such as tube feeding, ulcers, significant unintended weight change, and it gives the resident's name and comments and just like things to look out for. And this is a diet history slash assessment, which would be monitored monthly in the usual patients and weekly in high-risk patients. So interventions, another intervention uses supplementation. So in a study conducted by Garabala and colleagues regarding nutritional supplementation in the malnourished, there was 445 elderly patients that received normal hospital diet plus a 40 milliliter oral nutrition supplement, and there was 223 subjects that received a normal hospital diet plus a placebo. So this supplement included 995 calories and 100% of the reference nutritional nutrient intakes for vitamin and minerals for aging adults. Nutritional and clinical measurements were recorded 3 times over the course of the study to monitor the labs of these patients. So the result ended up oral nutrition supplementation of the acutely ill patients, improved nutritional status, and led to the reduction in the number of readmissions. So the supplementation group, only 29% were readministered to the hospital after they were let go, and then the placebo group, 40% were readmissions. So there was a significant difference with the supplementation group compared to those who did not have a supplement. So in conclusion, malnutrition in elderly is a rising issue due to the growing population and the negative economic effects that occur in institutions and in healthcare systems. Malnutrition commonly occurs in adults due to malingestion of foods, maldigestion of foods, malabsorption or increased need, or poor diet selection. It's really important to encourage regular use of the mini nutrition assessment, because malnutrition is frequently being undiagnosed, and not only is malnutrition a concern, but the risk for malnutrition, because if we can find out if a patient is at risk, we can more quickly get them on a path to recovery. So, and then once malnutrition or a risk is determined, we can determine if it's due to starvation, chronic illness, or acute illness. So recommended interventions include home visit consultations and oral nutrition supplements for the most successful recovery. And last, malnutrition really deserves increased attention because it has the potential to improve nutritional status and outcome of patients and economic benefits for the institution and healthcare system and the patient. Thank you.